Welcome everybody who's joined us to today's webinar delivered by HCV Action on the topic of micro-elimination. My name is Stuart Smith. I'll be chairing today. I work for the Hepatitis C Trust. We've got some great speakers lined up and I'll introduce them in a sec. Just to say as a broad introduction, ever since we started to hear the word elimination with regards to our disease area, hepatitis C, quite shortly after we started to hear micro-elimination, and it's garnered, I suppose, various definitions and meanings. Loosely, in my mind, it's when we're looking at a well-defined population, eliminating hepatitis C within them, and that could be a geographical area, it could be a prison, it could even be all prisons in a particular region, or drug services or drug service providers' own progress towards micro-elimination with it across all their services. On the other hand, I don't know what you'd call it. There's a few scientists I'm here today who are here today could probably correct me, but I think macro-elimination could probably describe what we're trying to do as a country as a whole. And as it happens, just as a sort of mention and a footnote, this week, some of our great scientists from England and our teams from UK HSA are going to meet with the World Health Organization to discuss our own elimination criteria at a countrywide level. And the WHO has a huge interest in our model. We do provide great healthcare and are often looked upon by the world for best practice. And we've done really well with our data and our modeling. So this week they're looking at it, and I think the process goes a little bit like they hear how we're going to monitor and track our own elimination, and then they sign it off and approve it and say, yeah, if you achieve all of those outcomes within your plan, then you are counted as having eliminated Hep C in England, Scotland, Wales. So moving on, we have some sort of general benchmarks. Is how many people are offered tests, how many people, for example, with a history of injecting have ever been tested, have you got a test date within the last 12 months, and then those who are positive move towards treatment and then treatment. So these are all markers that you could apply in a micro-elimination model. So today, to talk about the individual models in different settings, we have Tracey Kemp from CGL, and they have achieved micro-elimination in a number of their services. And Tracey is going to talk about the criteria that is defined for the provider forum, which is most drug services, as I understand, but Tracey will fill you in more, have signed up to a sort of criteria of how we're going to define elimination within our drug services. We'll then hear from Georgia Threadgold from NHS England, who will speak about prisons, and some of those have reached micro-elimination status, and Georgia will tell us more about what that status means and how it's monitored. And then we're going to hear from Professor John Dillon from NHS Tayside, who can tell us about micro-elimination at geographical level, and the work that's been done across Tayside to achieve micro-elimination, or at least get most of the way there. And we'll hear from John as to how we've been doing that. So we hope that the event will be useful for anyone directly or indirectly involved in trying to achieve micro-elimination in their own services or area. And we do welcome you to type questions into the Q&A or chat box at any point during today's webinar. After we've heard from the speakers, we'll have a little panel feedback and Q&A session afterwards. We are recording the session to publish it afterwards. And yeah, I think that's about it from me on the housekeeping. So with that, I think I will hand you to our first speaker of the day, and that is Tracey, who's going to tell us about micro-elimination in drug services.
Thank you, Stuart. Hello, everybody. My name is Tracey Kemp, as Stuart has just introduced, and I am the National Hepatitis C Strategic Lead working at Change Grow Live, or known locally on the street as CGL. And yeah, I'm going to talk a little bit about Hep C treatment within drug treatment services and how we kind of work to achieve micro-elimination. So if you could get me to slide 3, please, Elliot. Yep, next slide, perfect. Okay. So to help set the scene a little, I just wanted to kind of briefly share with you all some data around testing and treatment for hepatitis C in CGL services. So from the 1st of April 2022 through to the 31st of March 2023, so the last financial year, CGL services tested over 35,000 people for hepatitis C and other BBVs. We supported over 1,400 people into treatment, and we're kind of at a point where we're identifying around 1 in 12 people to be positive for Hep C, as opposed to 1 in 9 people being positive in the previous year, which kind of which shows that we are kind of heading in the right direction. Collaboratively, so Stuart mentioned the provider forum. So members of the provider forum are made up from ourselves, We Are With You, WDP, Humankind, Turning Point, the Addictions Providers Alliance, the Hep C Trust, NHS England, to name a few. And in the last year, we've tested collaboratively over 67,000 people. We've identified that over 4,000 people to be positive for Hep C, and supported over 5,000 people into treatment. And I think it's kind of fair to say that we have seen an unprecedented level of collaboration between multiple providers and organisations, kind of all working for that same end goal. Next slide, please, Elliot. Okay. So we know that there's lots of elements that contribute towards a service or an organisation kind of achieving micro-elimination. But I just kind of wanted to run through some of what we CGL would describe as some of the golden threads. So collaboration and partnership kind of says it all, really. This is about different disciplines, organisations, roles, sectors, coming together for the greater good, I suppose. There's no hierarchy within this. This is about working together, and kind of what has been achieved as part of the elimination programme over the past few years is a real testament to this. Screening and linkage to care. So this is about clear, easy, accessible testing pathways that involve all. It's really important to kind of embed a culture that sends that clear message that testing is everybody's responsibility. And as we know, we can literally test anywhere now. Yeah. Innovation and treatment pathways. So this has been a real process of, I suppose, evolution. We've gone from way back when people had to attend their local hospital to access treatment, to now kind of developing Hep C treatment pathways to be delivered by drug treatment services, by the people working in drug treatment services, kind of continuing, of course, to work closely with specialist teams and ODNs, but it really shows kind of where we were to where we are now. And then data and analytics. So this really is the backbone of how we evidence what we do and the impact that it has. It helps us be more targeted, identify trends, look at the areas where kind of we may need to pay a little bit more attention. Yeah, but whilst I am talking about the data and analytics, I just wanted to kind of give a little shout out to all members of the Provider Forum who recently were awarded a HSG award for Best Data and Analytics, which is amazing and kind of very well deserved achievement. Next slide, please, Elliot. Perfect. So we often talk about meeting people where they are at, or taking services out into the communities. And I just wanted to take a moment to kind of highlight some of the interventions or approaches that really do make a difference when working towards achieving micro-elimination. So the Hep C peers, the power of the peers, say no more really. I think we all know by now just how vital their role is and the impact that they can have, and we couldn't do what we do without them. Drive days and bring a friend initiatives. So we are seeing more and more access to health buses or clinical vans where we can literally take testing and treatment to people's front doors, and believe me, that literally happens. Understanding the data behind the story, I think we've covered this already, but ultimately without this we won't get very far at all. Harm reduction and needle and syringe provision. So if we are to eliminate and then look to sustain any sort of elimination status, then we need strong, accessible harm reduction, needle and syringe provision to be front and centre of what we do. And as I've already mentioned, new and innovative treatment pathways. Next slide, please, Ellie. Thank you. Okay, so when looking to the future of hepatitis C, there's kind of two key features or priorities that are brought together by two common themes, and that is to firstly eliminate hepatitis C, but then to sustain the elimination. And I just want to take a moment to pause for a second and reflect on an extract from the most recent shooting up report from UK HSA, and that is that insufficient provision of harm reduction poses a threat to our ability to achieve and maintain elimination. We must work harder to ensure that harm reduction is at the front and centre of what we do. And I suppose ensuring that we're engaging with those people who are yet to walk through the doors of structured treatment programmes, because we know that this is where the risk sits. And very much, I think across the board, it's fair to say that a lot of the conversation around how do we eliminate, how do we then look to develop sustainable models, all features around harm reduction and harm reduction pathways. Next slide, please, Elliot. So I think it's clear that there's a lot of fantastic work that has taken place and continues to be delivered on a daily basis across the drug treatment sector. However, there are some challenges that kind of remain. So a fatigued workforce, it's been a bit of a rough ride, and it's important that we look after our people. Harm reduction and NSP provision, we've talked about that. Reinfection rates is something that remains to be a challenge, and we need to keep our eye on this. Hep C treatment pathways becoming a core feature within drug treatment services. And what I mean by this is it's above and beyond kind of the core delivery in services, which does bring about challenges when looking to implement. So, you know, things like capacity, nurse capacity to deliver, but that doesn't mean that it can't be done. Engaging with those people who don't come into services or are yet to engage with drug treatment services, of course, remains a bit of a threat and a challenge. The project end date, so when I say project end date, I mean kind of the wider NHS England elimination programme. We know that it is a time-bound piece of work. We know that there's still work to be done, but we are, of course, kind of addressing that and trying to work collectively to look at where our priorities sit. And then stigma. Stigma still exists within certain communities, and we need to work to address this. Before I finish, I just want to kind of take a moment to talk about the micro-elimination criteria that was set out by the Drug Treatment Provider Forum. What I'm going to do in a moment, I'm going to drop into the chat a slide, just one slide, that highlights that agreed criteria that drug treatment services are working towards. So we agreed this collectively. There are some variances in terms of how we extract and collate our data, but ultimately what it does is it gives us a real focus around how we support services to get to where they need to be. So with that, I'll say thank you and hand back over to Stuart for the next speaker.
Thank you, Tracy. I think I'm back on. I've just switched my camera and microphone back on. Thank you very much. Did you say you're going to drop the criteria into the chat box?
Yes, I've got one slide that I'm going to drop into the chat. I'll do that.
Fantastic. Okay, so the chat box, not very active yet with questions. So please do, if you have questions that you'd like the panelists, I think we're going to hear from everyone and then we will look through and see what questions have been asked at the end and try and respond to them. But you know, whilst you're doing that, you can have a look at the micro-elimination criteria within drug services that's going to be posted in the chat shortly. So moving on. Our next speaker, Georgia Threadgold from NHS England, is going to tell us a little bit about micro-elimination in prison services. Are you ready, Georgia?
I think so, Stuart. Yeah, can you hear me okay?
Yeah.
Perfect, thank you. Hi everybody, my name's Georgia Threadgold. As Stuart's just said, I am a Senior Project Manager in the Hepatitis C Elimination Programme at NHS England. And as you can see by the slide, we were supposed to be having Sean Cox, the Prison Director from the Hepatitis C Trust here today, but he's a little bit tied up with something else in Scotland. So you've just got me, and hopefully I do Sean's slides justice as well. So we'll take it from there. So next slide, please. So because this is the only kind of prison-specific discussion in today's webinar, I wanted to give a little bit of background on how prisons are currently working towards micro-elimination, and to give a little bit of background. So I apologise to those of you who work in this area who know this. You talk about it all the time, but for those who potentially don't, this is a little bit of background. So for those of you who don't know, testing in the prison estate is important because we know that people within that setting are disproportionately affected by hepatitis C infection. So when this programme started, at least, we know now that the prevalence is a little bit less. The prevalence in the English prisons stood at around 7%, which is significantly higher than the general population. We also know that it's higher in the female prison estate than in the men's, and that it's very, very low in youth offending institutions as well. So to combat this issue, the Department of Health and Social Care set standards for full opt-out BBV testing at reception in all prisons in England. So to note, this goes just beyond Hep C testing and should include Hep B and HIV as well, which we always try and advocate that we test for all three. Full opt-out testing was introduced across the estate in 2018, where the uptake on reception was about 5% nationally, maybe 10% at a push. And the DHSC optimal performance standard, so the target for all prison, still sits at 75%. So the rate of growth in the first few years was super slow due to needing new ways of working, amendments to pathways and testing mechanisms, and then the ongoing struggle in prisons with a high rate of receptions. So because of this, NHS England began working with His Majesty's Prison and Probation Service, HMPPS, prison healthcare providers and Hep C Trust to undertake high intensity test and treat sessions, or HITs, as I'll refer to them in the rest of this, within prisons, which test the entire static prison population over a set week or so. Sometimes it takes 2 days, sometimes it takes 2 weeks, depending on the prison. So almost half of England's prison have had a HIT since the programme began, which is fantastic. And we've found an average RNA prevalence of 1.7%, and that goes up to 3.7% in the female estate. So the prevalence is significantly different. The reason that this is really important is it highlights how much prisons are currently doing in order to reach this micro-elimination target. The majority of the time, a HIT will be undertaken at the same time as changes to the effectiveness in a prison's reception testing process, and following a few months of strong performance, a nomination can be completed for micro-elimination, the criteria of which I'll get to in a bit. Next slide, please. The other reason that this is really important to mention before we go into detail about what micro-elimination in the prison estate is that it's important to mention just how many people, organisations and partners are involved in undertaking this work. So similar to what Tracey said about drug and alcohol services as well. In England, prison healthcare is commissioned by regional heads of health and justice at NHS England, who commission prison healthcare providers. And then with support of HMPPS, these providers are currently primarily involved in the reception testing process. So reception testing, for those who might not know, is the testing of people who are new into that prison establishment, either on the first reception, which is within the first 24 hours, or within the next 2 weeks. And we don't often see much bloodborne virus testing within the first 24 hours, as there are just simply too many other things that the prison and healthcare provider need to sort out within that time that are probably a little bit more urgent. But the reception testing includes transfers as well, just to note. So it's not people's first time in the prison estate. If they've moved around, it includes them as well. So reception testing can be extremely busy, and I think anybody on the call who works in that setting will say that that's probably an understatement, with some of the prisons receiving hundreds per month. It can also be a stressful time for the prisoner, which we've also got to bear in mind. So that makes it even more crucial that the healthcare staff are able to engage them in an effective way. So this is where the role of the Hep C Trust peers come in. So we do have some cases of peers being used on reception, but it's less common than their role in prison HITs and awareness raising sessions. And the HITs are peer-led initiatives as well. The peers assist in increasing the uptake of BBV testing and do an absolutely incredible job at assertive outreach for people who don't want to engage or refuse testing the first time that they're asked. Another way that prisons have managed to increase their reception testing in prisons is to get peers on the wings and undertake a variety of different tests, from point of care, dry blood spot, oral swabs, etc. So in addition to this, there's 130 current prisoners who volunteer as Hep C Trust peers who are currently in prison, which keeps that engagement and outreach up when prison healthcare staff are not able to do this. So the peers can deliver awareness training and support those who are currently on treatment to navigate their way through the pathway, which is obviously central to us ensuring that people have full adherence to their treatment regime as well. We also have a central role of the pharmaceutical partners in England, who are not only part of the strategic procurement for the treatment of the Hep C, but they provide innovative testing kits like oral swabs or Cepheid machines from AbbVie and MSD, and support to prison healthcare providers on their way through the pathway by the way of Gilead Sciences. And ultimately, this highlights how many different stakeholders it takes to work together to get a prison anywhere near micro-elimination for Hep C. And without those strong relationships to reach these targets, it's likely the estate would be in the place it was 5 or 6 years ago with their testing. Next slide, please. So I've spent a little bit of time explaining the way that we test in prisons and why it's important. But to celebrate this incredible achievement from the prison estate, NHS England came up with a way of recognising this through the awarding of micro-elimination. So the main thing that we want to get out of this information is that, number one, prison micro-elimination is extremely hard to achieve. So we're looking at a static population testing uptake over 12 months of 90%, as well as a treatment commencement adherence of 90%, and then a process for quarterly reviews. So ultimately, the target is technically 100%. We'd like to get everybody who goes through reception to uptake a BBV test. But due to the nature of prison environments, we know that some people can slip through the net, and others, it might not be appropriate to test them within that first 2-week window. So that was assessed that we should change this to equal to or above 95% uptake. And as I said earlier in the discussion, 5 years ago, the national average of reception testing was below 10%. So that any prisons have reached micro-elimination is an incredible achievement. The national average currently sits at about 70% for reference, which is significantly higher than it used to be, but it's clear that there's some way to go. The other main thing is that this means that just because a prison has been awarded micro-elimination once doesn't mean that they automatically retain that certification. So I would say that most prisons who have previously been awarded micro-elimination, they've lost that, they've not been able to maintain it, which is absolutely understandable when the criteria requires 95%. What we do understand is that there are several issues that affect the adherence to micro-elimination. So that can include prisoner and staff, to be honest, testing fatigue, staff shortages and annual leave. If there's issues 1 month in testing kit supply or lab time and processing, or simply just a really high number of receptions that the prison's not used to. So we know that there's many issues that affect micro-elimination. Next slide, please. But what we do know is that some prisons have achieved this. And for those of you who are aiming to get to this stage, this is what the process sort of looks like in a very simplistic way. So first off, we ask for all nominations to come from the Operational Delivery Networks, or ODN. Primarily, this is an assurance situation so that we can attest to the treatment figures. It also ensures that the ODN, as our kind of single point of contact from the Hep C programme point of view, is cited on the prison's achievement. That nomination is then sent through to a National Programme Oversight Board for Health and Justice, where there are representatives from the National Hep C Elimination Programme, the Hepatitis C Trust, HMPPS, regional heads of health and justice, and the UK Health Security Agency. And the data is reviewed at this meeting. Just to note that another point about the data is that it's taken from the NCDR dashboard, so formerly known as HGIPS. We know that there are loads of data quality issues through this dashboard, and we're working through them at a national level to resolve them. Unfortunately, that is the Commissioner dashboard and the data that NHS England has access to. So at this time, it's not possible to review prison data on an establishment by establishment, system one data level type basis. The reason I mention that is because I know that in a lot of cases, prisons have been nominated and the data that they have access to is different to what NHS England reviews it by. So sometimes it might be that NHS England refuses an application for micro-elimination. It doesn't mean we think that you haven't done it necessarily, just that we need to see the data in a different way. And just to note that NHS England remains able to support prisons with any data queries that they have around NCDR, and we will work with them to ensure that they can get that reviewed and micro-elimination can be awarded. So next in the little pathway, if the prison has met the testing criteria as per NCDR, the ODN has confirmed that at least 90% of positive RNAs are on treatment, and the prison has a process for quarterly reviews and outreach. A certificate and letter is sent to the ODN and sent to the prison. We then come together every 3 months to review that data and check whether the prison's still at 95%. And this is where it can get a little bit complicated. So if we review that data and the 3-month average after 3 months is between 90 and 95%, so less than the micro-elimination criteria, the prison's put on an amber watch list for 3 months until the next review. So it's a little bit like a 3 strikes and you're out kind of system. So since we know that there are several issues that affect adherence to the criteria, we don't want to be too heavy-handed on prisons in removing their award immediately. Instead, they're given 3 months to get themselves back to 95% whilst retaining that award. And if at the end of the 3 months, the testing has not improved, the micro-elimination status isn't re-awarded at that point. Next slide, please. So we can see on this slide that through the list of prisons that currently hold micro-elimination status, on the right is a nice long list of establishments that NHS England have currently awarded this status to. So this is just those that are currently awarded, not those that have previously been awarded and dropped off. As you can see, there's 18 establishments across England, which is absolutely fantastic. Of those 18, 8 have held that status successfully for over 12 months, which does show us that micro-elimination isn't static and proves just how difficult it is for prisons to maintain it. Many of these prisons that have held the award for a substantial amount of time have quite low levels of receptions, not all of them, but some do. So it could be argued that makes it slightly easier to maintain. However, it does also mean that if there are any refusals or it's not appropriate to test, the status can be lost quicker than in prisons with more receptions. So it swings and roundabouts. What is absolutely fantastic about this list is that it reflects different geographical areas and healthcare providers, male and women's prisons, and different categories of prison as well. So we don't yet have a micro-eliminated Cat A prison, but watch this space. But we do have some extremely busy local remand prisons like HMP Wormwood Scrubs that were awarded this certification following a successful hit for World Hepatitis Day, and have had an extensive outreach programme following that event. Just for another example, I guess, HMP Askham Grange is another prison to highlight, because I think it's perhaps the prison that's held the status for the longest amount of time. They've not just managed to achieve the criteria, but have also kept reviewing and undertaking mop-up sessions, meaning that they consistently achieve 100% uptake every single month, which is absolutely incredible. What's important now for the programme is to ensure that we get some best practice from a selection of these micro-eliminated sites, taking into account the different types of testing, the type of prison, different approaches to testing, and different healthcare providers. So each year for World Hep Day in July, we try to do a bit of a push or a drive to ensure ODNs nominate prisons in their patch for micro-elimination, as we know that there are some prisons that have probably achieved it but are not currently on this list. And as a national team, we'll continue to support any HIT events that will test the static population, and we will work with them to continue testing through a robust reception testing process. Next slide, please. So to summarise, I've put the handful of takeaways that I want to ensure that everyone has at the end of this presentation. So I guess if you remember anything, it would be these things. So firstly, there's a reminder to ODNs that prisons can be nominated at any time, and that also includes those prisons that were previously micro-eliminated and have dropped off the list. We don't have any issue with people coming back and saying, we know that they dropped off for 3 months, but we know that they're back testing at 95%. And for those areas that are still struggling with meeting the criteria, the offer is open for us to assist with any pathways, processes, different testing options, HIT sessions, further awareness raising from the Hep C Trust, data assistance, or literally anything else that we can do to support. The next point is that micro-elimination status isn't static, and we do need to be tight with the criteria and robust with the reviews. Thirdly, we acknowledge that for some prisons, this may be either a way off or may not be possible at the current time to meet micro-elimination, and being removed from the list of certified prisons is not meant to be punitive or shameful in any way. The micro-elimination status is a really aspirational target that we know might not be approachable for every site at every moment. We do know that how much work so many partners put into it, and showing people within the estate are routinely tested, but we also acknowledge that in the backdrop of staff shortages, testing fatigue, and competing priorities, this is super difficult. However, the offer of support is always there for us to assist with anything that we can. And I know that Sean, if he were here, would want to reiterate this from the Hep C Trust perspective as well. So finally, I just want to give an acknowledgement that it takes an incredible amount of work from so many different stakeholders and a huge team effort to get prisons to where they currently are. And I can't emphasise enough how about 4 or 5 years ago, when I started in this programme of work, that it was normal for prisons to not test anybody at reception or to test just a handful of people. So although we know that there's some way to go in ensuring that all prisons are micro-eliminated and we push towards England's broader elimination goal, we must acknowledge how far the system and partners have come in a short space of time. So for that, I want to say a huge thank you to you all. The next slide is just my contact details. So if there are any questions or any nominations or any clarifications that anybody wants around the criteria and how that works, please don't hesitate to get in touch. Thank you.
Thank you so much, Georgia. I echo the fantastic work done across the country in our prisons, and thanks for delivering a presentation that shows just a great accreditation scheme and how you've been able to put that together, how you monitor it. I think that's really useful. Hopefully others on the call will find that useful. So I'm going to hold more discussion at the end with the Q&A. I'm still hoping people are going to type some queries into the chat box. I see that the criteria for micro-elimination in drug services in England is now available if you click the link through to HCV Action website if you want to see that. But please don't do it while our next speaker has agreed to join and share about Tayside. So I'm going to move to John Dillon, and I'll let you introduce yourself, John, and what you're doing here.
Thanks very much, Stuart, and thank you for the organisers for the invitation to speak. It's always a pleasure. It will be nice to get back to doing these things face to face rather than a flat screen at some point. So on the right hand side is a map of Scotland. We have 14 health boards, and in dark blue is the health board area that I'm responsible for as NHS Tayside. And so the way treatment is organised in Scotland is rather like your ODN, or not like your ODNs in England, but each health board has the duty of care to provide hepatitis C therapy and diagnosis for the residents within its board area. What I'm going to talk about in Tayside is the 5 pathways of care that we have for delivering treatment. And we've already heard about the drug treatment centres and the prisons from the previous speakers. So the 5 pathways are the standard sort of primary care, secondary care referral process that happens for all diseases. And that still happens there, although it's largely nurse delivered in Tayside. In large pharmacies, we have pharmacists who are trained to do dry blood spot testing for hepatitis C, and then to organise blood tests and to prescribe and dispense therapy. For the smaller pharmacies, the pharmacists can do the dry blood spot testing, or we have visiting nurses that sweep through an area at a time, treating all of the people who have hepatitis C within those pharmacies, and that's predominantly focused on the people who are picking up opiate substitution therapy. Similar pattern of process in the drug treatment centres, with in-reaching nurses supporting the addiction workers in the testing and the provision of treatment. And similarly in the prisons, we have the prison nursing staff doing dry blood spot testing on admission. And again, we have an opt-out system in Scotland, although it's not as efficient and well established as the one in England. And we're exploring the options of using HIT type interventions. But for the 2 prisons in Tayside, we have it working relatively well. And we've also invested a lot of effort in our needle and syringe exchange programs, particularly the large fixed site ones in our 2 big cities within our geographical region, which provide a lot of the care that's going on. And that's provided by the embedded harm reduction nurses. Next slide, please. But all of those pathways require a diagnosis and treatment. And the key part of all of this is to provide those services as close as possible to the people that we need to reach, and in environments where those people are comfortable. And we did a discrete choice experiment to ask our clients, customers, people what they wanted and what they valued most. And going to their own pharmacy that they were familiar with rather than an alternative pharmacy, they were prepared to wait over 4 weeks. To go to their own pharmacy rather than having to make an appointment with their GP and go and see their GP, they were prepared to wait over 2 weeks. Their key worker or drug worker or their own pharmacy, they were equally prepared to do either. And to be treated with respect, they were prepared to wait 7.5 weeks, which is an indictment of the services that we were running at those stages. And clearly that's an important part of that feeling comfortable, being treated with respect, is how we engage with people we want to reach around hepatitis C treatment and cure. Next slide, please. The key to making hepatitis C treatment work is getting the diagnosis, and we need to make the diagnosis as simple as possible. We've used a lot of dry blood spot testing. I can train anyone to get blood out of a finger, okay? It may be more difficult to get blood out of a vein, but anyone can get blood out of a fingertip. And so in the picture in the bottom left-hand corner of the slide, the blue device is a puncture device. If you press the blue trigger, a needle shoots out and shoots back in again, and you've got it pressed against the side of the finger when it does it. That will generate enough blood for you to fill the 5 spots on the card, from which you can get a Hep C antibody, Hep C PCR, hepatitis B surface antigen, or an HIV antibody. We use it where venipuncture is difficult, not because it's difficult to get blood from someone, but because the staff around don't have the skills to do venipuncture. And that may mean teaching nurses to do it, teaching non-medical staff to do it. And so the majority of the people that we've trained to do dry blood spot testing have no medical or nursing qualification at all. Okay, next slide, please. So if you can test, and we can teach you to test, you can read the result, you can give the result back to the patient, and you can then refer the patient. So you become part of our network. And that's the key part of this, as the previous speakers have alluded to, the collaboration and agencies working together by sharing our skills and technologies through the whole possible care of pathway, and getting the focus around using those people who have trusted relationships with the people that we're trying to reach, getting them into treatment. This next slide shows the impact of dry blood spot testing when we introduced it in 2009. And the dark blue parts of the bottom of the graph were drug and alcohol services, who had, you would expect, to be providing lots of the new positive diagnoses, and were doing very little until we introduced dry blood spot testing. And it was predominantly the needle exchanges that caused this surge in the numbers of new diagnoses. But I draw your attention to the fact that the rest of the graph didn't change. The whole overall, it went up, but the proportions that were being diagnosed in the other services continued. And so this test was reaching the parts other tests couldn't reach. It was reaching people who had previously not been able to access testing. And that's a really important point to take home. That change in using technology shifts it through. Dry blood spot tests are the advantage that they're cheap and easy to do. If you want to use a point of care machine and you can keep the person that you're trying to engage with hanging around for an hour, that's fine, and you've got the money and the technology and the technical ability to use it. But dry blood spot tests are simple and cheap and work just as well, particularly if you're using them where the person is returning to anyway, for instance, picking up needles or picking up opiate substitution therapy. Next slide, please. So this is all of Tayside's testing data ever. So it's about 150,000 tests or so over the years that testing's been available. So you can see that our colleagues in general practice have done about 27,000 tests, and they're getting 3% positivity for PCR. In secondary care, we've done nearly 80,000 tests and have a 1% pickup rate. In addiction services, they've done a few thousand tests and have picked up 12% positivity. Community pharmacies, a few hundred tests and have picked up 11% positive. The needle exchanges, again, a few, perhaps 1,000 tests or so and picked up 26% positive. And the prisons, more tests and 14% positive. So you could think, let's focus on those special pathways because we have a really high pickup rate, which is a good point. Next slide, please. But if you look at the total number of people that have been diagnosed, about a third of them have come from those tests within general practice, about a third of them have come from those tests within secondary care, and the other specialist pathways with a much lower volume of testing have found the other third. So we need all three of those general large pathways working to reach the whole population if we want to think about regional elimination or micro-elimination, whatever you want to call it. So it's that integration of all of the pathways working together. And it's equally important to realize that the people who are diagnosed through one pathway don't necessarily get treated through that pathway, and we need the ability for the information to flow between the different pathways. Next slide, please. So within pharmacies, we've done trials showing that if you have testing and treatment within pharmacies, it works. Next slide, please. And if you're in a pharmacist-led pathway where you are doing the testing and treatment where you start within the pharmacy, rather than signposting people off to treatment elsewhere, you have a 2.5 times increased chance of getting your treatment completed. And that drop-off is around the treatment, it's around the diagnosis bit. Once people make it to the diagnosis step, then the differences fall away between the two steps. And so it's that first bit of making that diagnosis, because once you're diagnosed, moving on to treatment is much easier. It's much more fearful making that first step into diagnosis. And so making the diagnosis really easy by the pharmacist having a conversation and doing the test there and then, rather than the pharmacist having a conversation and sending someone off somewhere else to get the test done and to come back. And so you can reach really high cure rates in terms of across that board, even in areas where there's already been a lot of treatment availability through drug treatment services. Next slide, please. And next, and next. And so in the REACH study, we were doing this within pharmacies where the rate of numbers of patients with opiate substitution therapy were lower, and so it wasn't worth training the pharmacists to do it. And we had a nurse who would come into the pharmacy, be there for a couple of days, do all the testing, and then move on. This was pre-COVID that we did most of this study, and so daily pickup of OST was much more common. Clearly that's changed now, and so we'd have to change the timelines. But it's this idea of an in-reaching nurse clearing a pharmacy at a time, so micro-eliminating in that pharmacy and moving on. And again, it was in those areas where the test was offered and provided on site, uptake was much higher, and the numbers of people who initiated treatment were similar between the two arms. But that movement into testing, where you had to go elsewhere to get your test, was the big drop-off. So it emphasizes the importance of making the test easily available, and then it's relatively easy to link it to care, particularly if you're in the same environment. Next slide, please. And the cure rates were similar before. And the advanced study was based in needle exchanges. We'd done a lot of treatment in needle exchanges and interferon ribavirin days, but clearly there was a long relationship being built up with the clients that we were moving forward to treatment because of the complexities of using interferon. With the simplicity of the DAAs, the idea was that you couldn't possibly give £40,000 worth of drug to somebody who was actively injecting, and that it would just never work. So we did a trial comparing directly observed therapy, which is clearly a pain to have to participate in, where you have to turn up every day to get the drug, as opposed to fortnightly provision, where you turn up once a fortnight, roughly the time you're picking your needles up anyway, and have the drug provided, and then the final arm was a fortnightly provision with a psychological intervention to encourage adherence to therapy. And overall, there was no significant difference between any of the arms. All of the patients achieved high levels of SVRs, and there was no difference in any aspect of it all. So trusting the people that you're trying to treat, giving them the drug, and building a relationship with them, they will take the drug. And as one of them turned around to me and said, "Hey doc, we're professional drug takers, we can take tablets." So that's the important thing to bear in mind. And so within the needle exchanges, again, you can keep it simple and move things forward. Next slide, please. And again, this is just the result showing no difference. Next slide, please. So overall, as we started to move in 2017 to 2016 to think about trying to remove hepatitis C from our community and to test the idea of treatment as prevention. So if you did enough treatment, could you prevent the transmission of the virus? And so we used all of these pathways to have a surge of therapy to try and get the 800 people who are estimated to be chronically infected with hepatitis C into treatment and clear them through treatment. And we managed to deliver that numbers of people into treatment, and we're in the process of following up to see whether that has a definitive effect on the risk of onward transmission of hepatitis C, and we'll have data on that in the coming year or two. Next slide, please. And if you look at where the heavy lifting was done within these things, so this is our 6 pathways of care, and in each of the groups of circles, the circle on the left-hand side, as you look at the slide, is the number of treatments that they provided. And so the prisons and the nurse-led clinics and the drug treatment services in the conventional care provided some work, but over half the patients were treated through the community pharmacists who were on opiate substitution therapy or in the needle exchanges. And if we want to achieve elimination within our populations, that's the site we need to get to, and you need to build those relationships within community pharmacies and needle exchanges to try and get that levels of treatment up to those levels, because they are seeing people much more frequently than our drug treatment centers were seeing even pre-COVID, and they're clearly seeing them a lot less now. But again, SVR rates were similar across the whole board in terms of those that were proven and those that were assumed because of completion of treatment. Next slide, please. So if we now stand back and look at the whole population across Tayside, both those people who are active, who are still actively engaged in drug use, and those who have Hep C for other reasons. If we take the World Health Organization, initially it wanted to achieve 90% diagnosis and 80% of those to receive treatment. And as Stuart has alluded to already, they've changed their criteria for achieving elimination and want incidence studies, which are harder to do, but we can negotiate with them as to how and why, how and when we can get to those. But if we take an old-fashioned way of doing this, so if we take the population of Tayside and assume that 5.5% of our population are prevalent carriers of hepatitis C, for the size of Tayside's population, that will be 1,975 people. And so if we wanted to achieve, and 90% of that chronic prevalence is 1,776. So if we look at the total number of patients ever diagnosed in Tayside, that's 4,322 people, and they've had 4,535 infections because we've had reinfections. Of those 1,043 are PCR negative, 703 are no longer resident, 698 have died, sadly, many from drug-related deaths and some from hepatitis C-related deaths. And so that leaves us a total of alive and living in Tayside of 1,878 diagnosed. So we've diagnosed well over 90% of our prevalence, and in fact there are 97 patients left to find in Tayside if our prevalence estimates are correct, but there is an uncertainty around all of those things. And of those 1,878 patients, we had cured as of July 2022 1,812 of them. More of those have now been cured, but equally more of them have become reinfected, although that rate's falling. So we have achieved World Health Organization old criteria for elimination across Tayside, and whether you call that regional systematic elimination or micro-elimination or whatever you call it, it's one way of measuring elimination and how close we are. What's special about NHS Tayside? Absolutely nothing. If we can do it, you can do it. Next slide, please. Thank you very much.
Thank you so much, John. Thank you for delivering that. It's very interesting. In fact, to that final slide, I was thinking my first question to you, John, would be, do you think you achieved elimination in Tayside? But I think I can enlarge on that in that I understand what you are saying about treating your way towards elimination, as that's sort of a method that you can adopt. But I think you started by saying you've got oversight of Tayside, so that's a big responsibility. So you're the person I'm going to ask this question to. So what metric do you think is the most important metric now for you to not lose sleep at night and think, actually, we're maintaining this level now? And where do you get that data from?
So it has to be ongoing regular testing, and whether we do that to measure incidence or to measure prevalence amongst those patients that we're retesting, but it's keeping that testing enthusiasm going within the prisons, within the needle exchanges, within the drug treatment services. And if we know the prevalence stays low within those environments, we can be confident that it's not spreading elsewhere in the community, and that we've cleared that number and it's staying clear. But it is that regular testing, and so everybody with an ongoing risk factor should be having an ongoing annual test. But how we, the testing fatigue that Georgina has alluded to already, and trying to maintain that level of testing when we're all working on time-limited budgets, as Tracey alluded to previously, is going to be important. I think it's important we don't lose sight of that. If we, Glasgow in Scotland had that experience of they stopped HIV testing along with Hep C testing because they hadn't had HIV outbreaks in drug users for 2 decades, and they stopped testing, and 18 months later we had the biggest AIDS outbreak in 30 years. And that's the importance in getting that message across.
And thank you. And I mean, in your presentation, you alluded to at least 2 or 3 huge studies that have been done in Tayside. So does that keep the pressure on? And what happens when the studies finish?
Well, those studies are all now historical, and we've done them, and we then, because they were successful, we adopted them into routine clinical practice, and so they've continued. Clearly, we're now, because we've largely treated everybody and we're just in the mopping up phases, we're sort of redoing them, but where the focus is on testing, because we're not expecting to find many cases. COVID has had an impact. Our testing programs, as with everybody else's, fell away considerably because we were all redeployed to other things. And whether that reduction in the availability of services, etc., has had an adverse effect on prevalence, that's what we're piecing together at the moment. So far, with the testing that we've done, we've not seen a big surge within the needle exchanges, but we haven't managed to reach into the populations that are on OST deeply enough yet to be certain about that.
Oh, thank you. Okay. And I would never publicly disagree with a professor ever.
Oh yes, you would, Stuart. You've done it before.
I would say that Tayside is quite special, and even if it's not special in Scotland, which I think you're right. You know, for us in England, it's important to understand that we have a lot of broken up services. And I think I'm right in saying that everything kind of sits within the NHS in your area, doesn't it? Right down through the drug service, the needle exchange.
Yeah. So we have charity providers of some of the drug services, but they're commissioned by the NHS, and so there isn't a sort of a lateral movement of money between us, which means that we are able to get on and collaborate in a way that's not so financially driven in the way that many of the services in England, you know, it's the first discussion is around who's going to pay for it as opposed to who can do it. And, you know, I think, you know, Tracey was very eloquent about the way she described that collaborative spirit that has been built up across England, which has really sort of revolutionized and changed things, because, you know, we were able to be slightly superior a few years ago about the things to work together, and Graham Foster would be pulling out his rapidly greying hair about not being able to copy what Scotland's doing, but clearly you've cracked a much more difficult problem and got that sustained now. So I think that fragmentation was definitely there before, Stuart, but I think you've done huge work in breaking it down. And it still happens. Everyone has their own little empire and their own little castle that they want to defend, and getting the idea that you can delegate treatment responsibilities and decisions out of hospital and out into the community is still a struggle for some colleagues.
Okay, thank you. So I'm going to stop grilling you now, and I'm going to take a question from the chat. Simon Packer has put a question about the top priorities for achieving micro-elimination. So I'm going to ask Tracey, if you were to choose within your service delivery, where is the top priority at the moment? Where are the breaking points? Where are the places that actually need to get the micro-elimination down in drug services?
So for me, it's at the front door. So what we call entry into service. You know, making sure that you've got those testing processes that happen at the earliest opportunity, and not kind of once people are settled or in structured treatment, because that can make or break, you know, the difference between somebody engaging or not. And I think underpinning all that is the harm reduction offer. Maybe engaging with those people who are yet to walk through our doors and access any sort of structured treatment. So yeah, that's where I would most certainly put myself, Stuart.
Okay, thank you. And I think the same question to Georgia. I've got another question of my own for you, Georgia, so get ready for that. But within the prison settings, what are the top priorities at the moment?
The top one that is more in control, I suppose, of prison healthcare and the prison. So not things like resolving staff shortages issues, because that's a different question. But the top one for me is ensuring that when we're talking about testing, that the offer is a true opt-out testing offer. So we're not talking about when someone's at reception and goes, you know, I don't want a test. I've just had one 3 months ago. I can't be bothered to do another one. Let me get to my cell. That is the offer that's presented to them is a no, we're going to take that blood unless you tell us a good reason as to why not. And if not, how can we get that person to change their mind? So usually that would be peer support. So ensuring that that person is linked in with somebody who can speak to them, have a conversation with them, however many interactions that takes to get them to understand that this test is really important, and it's not really an offer. We sort of saying we really, really want you to have this. There's good reasons as to why we want to have the opt-out testing. So yeah, ensuring that the opt-out offer is true.
Okay, thank you. Hopefully that's answered the question, the great question from Simon Packer in the chat. Please, if you've got any questions, please post them in the chat and we will pose them to the panelists here today. Back to you, Georgia, just something that cropped up with this idea of people losing their accreditation for elimination status, and how are the feelings amongst the ground teams when that happens? Is there a danger that we get into some fatigue there where people do a lot of effort to get it, but then actually when it's not there, how many times are they going to go back to try and achieve it and keep that maintained?
Yeah, it's a huge issue. We have it every time that we contact prisons and say, unfortunately, we've reviewed the data and it doesn't reflect what we would consider meeting the micro-elimination criteria. So this comes up a lot. And what we are mindful of is not affecting staff morale. And that's why I kind of mentioned about removing discrimination isn't meant to be punitive or shameful. We're not saying that the prison isn't doing a really good job. You know, in one instance, let's say a prison's been achieving 90% for several months. That's incredible, and it's significantly above the optimal performance standard, what DHSC recommend for reception testing. So we're not saying that the reception testing is poor. It just means that that micro-elimination status hasn't been maintained. And we're at a stage in the programme where we have to be really confident, if we're talking about micro-elimination and elimination as a wider achievement, that we are confident that that has been met. So unfortunately, it's one of those, I mean, we consider all the time whether they're quite tight, but at the moment we're not considering making it any lower than 95%. So yeah, we want to make sure that we're not saying the door's closed, you can't meet micro-elimination anymore. We're saying that at the moment we aren't confident that the prison's maintaining it at that moment in time, but we're here to support and we're happy to review micro-elimination again for that same establishment. But it is a tricky one.
Okay, thank you. Just so you know, John, your certificate's in the post. We're going to send you a certificate out for it, for eliminating Tayside.
I look forward to it. You're going to send us one when we manage the whole of Scotland?
Yes. We said
I think you get more than a certificate for that.
Well, I've got a question from someone sat next to me saying, are Scotland going to do it?
I think that looking at we've only just got our epidemiologists back from the dreaded COVID projections and pandemics, and we think there are about 9,500 or less people left in Scotland with hepatitis C that hasn't been cured. And back in 2017, when we set our original elimination targets, it was to get from 50,000 down to 5,000. And so we've got 4,000 and a bit to treat in the next 2 years. And so if we got back to our pre-pandemic treatment levels, it's possible, but it requires quite a bit of effort. And we also have the issue that what we achieved was with some health boards, particularly Greater Glasgow and Clyde, doing very well, and they've done a lot of work. But it means they can't work because they're running out of people, and it's the other health boards that haven't been as proactive that now need to do more. So that is, as I think Tracey alluded to, it's bringing up some of those areas that aren't performing as well as the others, and so it's getting that group, the whole lot, moving up, and that's going to be more of a challenge. So if the Hep C Trust or anyone else has got some good ideas how to improve that part of the performance, we'd be really keen to hear them.
Well, it was Rachel who was asking the question, sat next to me here. Well, I look forward to that. Eyes on Scotland. And I was going to ask Tracey, so do we have plans to keep some kind of record of which services are achieving the drug service criteria?
Yeah, so that is being worked on as we speak. So we're kind of, again, we as the provider forum are developing a bit of a heat map, if you like. So a map of the country where we'll be able to kind of, it'll be on a live website, so it will be updated as and when, because we all know that micro-elimination is a moment in time. And we'll be able to put the services, the locations on that map have achieved kind of that micro-elimination status for us to keep our eye on, and also kind of use it to, if you've got a neighbouring service or city and they're struggling a little bit or want to kind of share some best practice, you can kind of have a little look, work out who's on the map and then make contact. So yeah, watch this space.
Thank you, Tracey. So Georgia has had to dash to another meeting. We still have John and Tracey, so please, if you've got any questions, please post them in the chat. We might finish early, but we've still got some time. I've still got a few questions. So another question to John with the word reinfection in it. So in my mind, and I'm not a data analyst or scientist, but I kind of believe that reinfections are a natural part of the hepatitis C story. I know you get a lot in Tayside, or your fair share. For me, it's if we are down in services in England, for example, and we're not seeing reinfections, do we think that that is an indicator that we're not doing the testing and the maintenance to ensure that we're keeping the program alive?
So in our experience, having delivered a lot of treatment into people who were injecting drugs, we saw a spike in reinfections, and then we treated those people and carried on treating, and then that reinfection rate was going down. So in terms of numbers, we were seeing 24 per 100 patient years reinfection. We're now down into the 3 per 100 patient years with the same volume of testing as before. So a dramatic fall off, and that makes sense because if there's less people around who are injecting, who are Hep C positive, they can't pass it on. That doesn't take much. Back to the question you asked me previously, it's that sort of keeping the testing going, and you've got to be open to retreating people as quickly as you find them, and you want to have a conversation with them about, you've got it again, who are your pals and do they want to come and have a test done? We'll give them some vouchers or Keller, whatever will make it happen, that they'll be prepared to pop in and say hello to us.
Okay, thank you. So it says here there's a few questions in the Q&A. I'm not a Zoom whiz. Is there another page of Q&A that I should be looking at? Yes, sorry, there's a bottom box. There's a question from Simon, and I'll come back to you in a sec because I've just found a new box. So someone who's anonymous has said, is there a danger of losing momentum when trying to maintain micro-elimination rather than reaching it in the first place? So I think this is to do with the fatigue, and how do we combat this? Does anyone want to have a go at how do we combat this?
Yeah, I can go. I think it's all about how we kind of set our stall in first place. So we know we're working towards a service kind of calling micro-elimination. It's a moment in time piece of work. It's not a kind of we've achieved it, we're done. And I think as long as you set that culture in place, that actually this is to contribute to the bigger picture of the kind of the wider elimination plan, and staff are really well connected to it, I think that kind of eliminates some of that, staff feeling disheartened, for example, should they lose an elimination status, as opposed to, look what we've achieved, now let's keep going. I know our example, an example from CGL, our services over in Halton, you know, they are working really hard to kind of maintain a status of, you know, we've been able to call micro-elimination, keep kind of motivated and morale high where possible, given that we know staff are tired, fatigue has kicked in, but if we're aware of it, we can do something about it.
Mm-hmm. Yeah, I mean, I was always a big fan of showing people case when I was training doing workforce development in drug services up and down the country. You know, you had to give it a personality and say you're actually saving someone's life, someone's dad, someone's, you know, because that about hepatitis C, it's so easy to treat now, but actually if it goes undiagnosed, it becomes a different story for that patient. So putting it into that personal perspective can, I think, helps people, you know, just understand what great job they're doing. So the next question is could be seen as a gripe towards NHS England, but I'm not. I'm going to just joyfully brush over it. Someone wants to hear about what it means by meeting patients where they are. They have suggested that they've been trying to get a van in the north of England and not been successful so far. I think, John, probably meeting patients where they are. If you want to enlarge on some of those settings, did you use a van at all in Tayside?
We couldn't afford a van, so we stole places. So basically, wherever there was a space, we would pop up in it. So that was how we got close to people. So it was places where people were already attending, so people were already, you know, where the environments they trusted and knew, and weren't having to go somewhere new. So yeah, where their needle exchange or wherever they were picking up substitution, a congregation, and that included some recovery cafes and things. And so we would pop up anywhere and got into the habit of appearing on a regular basis there, so people knew that we were likely to be there and we would be making contact with them, etc. So that was how we got round not having a van. There are upsides and downsides of the van. I mean, it's again, if you've got a van, you've got to know where to park it and where it's going to be useful. I can completely understand in some city centres where you've got a lot of street injecting and a lot of homelessness, the van is going to be vital because they've got nowhere else to go. And we've certainly, you know, the Salvation Army soup kitchens and what have you, we've on occasion done some mobile testing out of the back of those sorts of things, so that we have done it, but we've never owned a van ourselves.
Okay, I'm going to move quickly through some of the questions now that I've found them all. We've also been asked how we are going to ensure consistency. Big differences in England and Scotland, but someone has suggested here that even in England, you know, anyone can do a finger prick test, but actually there's quite variance over that practice in itself. Would either of you like to have a go about the consistency across you know, the nation?
I can talk to England first of all. I think there's always going to be an element of variance in kind of testing methods, and that's okay, because we need to kind of have a menu of options meets the needs of the people we're trying to engage. I think in terms of how we work to have a real consistent approach, you know, and I keep talking a lot about the provider forum, but the collaboration and the partnership piece around sharing, being really open and transparent about different ways of working, or what, you know, barriers we've come up against, really helps in move towards that consistent approach. So for me, I think it's just about working together. Something that I am of is that not all providers and grassroots services, for example, are connected to the provider forum, and that's something that we've identified as actually a bit of a red flag, let's say. And as providers, we've kind of committed to identifying who those people are, those organisations, and kind of reaching out and supporting them in kind of joining us, coming on board, to make sure that we've got more of a consistent approach, and it's not just necessarily the organisations that are part of the formal elimination programme, let's say.
Okay, thank you. Another question here for from Emma Lamond. We are with you. And I'm going to throw in my own little bit towards John on this one. So I think this is okay. Micro-elimination is, we've seen that we can define a group. So we could define injecting drug users and then say no injecting drug users have got chronic Hep C anymore. But I think Emma's question is more about beyond injecting drug users. And with that, I'm going to throw in, has there been any A&E testing, general population testing? I know you had some data, John, but any plans to do anything similar to what they're launching in England or have done in England, Manchester, Blackpool and Sussex with the ED testing?
So I think ED testing is happening in Scotland, not at the speed that we would like. There is some resistance from some ED doctors, but we are breaking that down and moving forward with it. So reflex testing on all bloods that are done in A&E is starting to happen. It's happening more effectively in Glasgow than in some of the other cities in Scotland. And we're seeing a prevalence of about 2 or 3%, but that seems to be falling as treatment processes get more effective. Within general practice, there's going to be, if you think of the population that could have picked up hepatitis C at any point in their lifetime, there are going to be people who have a problem with drug use and come to medical and end up with a medicalized model of how they're looked after, and that appears in their medical records, and so we can find them if we were looking for them down the line, and they have had contact with drug treatment services, etc. But there are equally a population of people who injected for a while, never really had a problem with it, and quietly moved away from it and are in society and untouched by it. You can throw in some dental work and some blood transfusion patients into that as well, and other random routes of transmission. Those patients have hepatitis C. They don't have an obvious risk factor that if you've got a risk factor based testing thing that you'll ever find. And so it's then that routine testing. And in Scotland, we are starting to roll out intelligent liver function testing, where if your blood comes into the lab and your liver tests are slightly abnormal, you get a whole host of tests done to look for the causes of that. And one of those is Hep C and Hep B, etc. So we can do that. And doing that, we're finding out in our population, despite the fact we've done a lot of Hep C testing within that general practice population, we're finding about 0.25% of people are Hep C positive, and over half of them have never had any contact with screening services and have no record in any of their medical records that would give us any clue as to how they got it, etc. So that's about, over the last 4 years doing that routinely, we've picked up about 80 people.
Okay. Great, thank you. We have another question from Simon, asked contact tracing in supporting micro-elimination. I think I'm going to add my bit to this because Tracey, with regards to the criteria for micro-elimination in drug services, it has been decided that we can only really do that with open clients to that drug service. However, we know that also the needle and syringe program that might or might not be commissioned by that drug service also has a sort of mini assessment coming in for clean equipment, but those people are not included in the criteria for micro-elimination. So I think with Simon's question on contact tracing, do you want to speak about, I think with the micro-elimination criteria for drug services, there's a core aim, but there also is an expectation to be providing some of those after interventions to try and dig deeper into the community, isn't there?
Absolutely, and I think yes, the criteria focuses on people who are previous or current injectors in structured treatment. However, as we all know, those people who are accessing our needle and syringe programs, this is where the risk sits, because potentially, yes, they may be our future people accessing structured treatment, but a lot of them at that moment in time aren't. So it's really important that there's an offer available that kind of meets the needs of different groups of people. And again, something that has been highlighted collectively as a little bit of a red flag to the wider elimination piece, in that let's not get lost in just focusing on people in structured treatment, when actually we know that there's a whole host of other people out there that absolutely need our support, need to be tested, still need the same access to treatment.
Okay, thank you, Tracey. And question for John, maybe. Any lessons learned from the pandemic? How to be more resilient in big public health incidents in the future?
I think that the lessons learned from the pandemic are that, things that we had tried for years to get changed, and everyone said it was impossible. Throw a pandemic at them and they managed to change them in about 12 hours, particularly if it meant that they didn't have to be patient facing or going out into the big wide bad world. So I think we can use that as an element of, you managed to do it during the pandemic, you can do it now. And so we can change things. So that's a positive. It shows that we've got to be adaptable. I mean, clearly a lot of our pathways across Scotland were based on that frequency of people using services and crossing thresholds, and we changed that dramatically because people are now accessing thresholds a lot less often. But it does mean that there's more time and more space. So whereas before there was queues of 60 or 70 people to pick up methadone, now that they're only picking up, most of them are picking up weekly, it means the queue is 10 rather than 70. So you've got that potential to have more time with the client, more time with a person that you want to have a conversation about. So I think that's using those opportunities that have now changed, but we've got to think flexibly and from a plastic point of view. Bolting Hep C therapy onto pandemic testing and other COVID interventions, there's been quite a lot of publications. Most of them have shown it didn't work very well. Partly because it was the difference between having a swab was bad enough, and then having someone stab you in the finger as well was just a step too far.
Well, I read somewhere over the weekend on the BBC that a lot of us in England are going to receive a big message on our phones on Sunday as an early warning system. And they've described it as possible pandemic outbreak, natural disaster, but who knows with what's going on, nuclear war, whatever it is. But it could be, Hep C's back once we've squashed it. But okay, that's great. So and just to add there, John, I mean, our peer program, so as you know, recruiting people with lived to do things like the fingerprint test. And in fact, that statement that you said again today is something I picked up on years ago when you said it, which is if you can read a line on a whatever you call them, the tray, then you can do a test and you can diagnose someone. And so we've actually done about 30,000 tests of our volunteer peers last year, and that was up from 19,000 the year before. But what we got from the pandemic, very similar to what you were saying, John, is immediately where we weren't able to do this, no, you can't do that, you're only volunteers, no, you can't do that, you're people with lived experience. It changed the game for us. All of a sudden, there was a lot of regulation and red tape come down. And I know the red tape is important for governance and keeping people safe, but still there was, sensible movement of some of those restrictions, which really changed how we deliver our service. That's fantastic. We've talked about micro-elimination in drug services, in prison settings, and in a whole geographical area of Scotland. So I'm going to ask both of you this one after the other, but I'll go to John first. Micro-elimination, would you choose another set? Is there another setting in your mind that needs to be targeted? Is there another group of people? Is there, where else might we look to adopt a micro-elimination?
I think it's micro-elimination strategies often need a champion to lead them. And so it's someone who says, I'm going to be that champion, and it's whichever environment they're working in, be that a prison, a drug treatment services, within a needle exchange, within a hostel, or anywhere where they have that sense of responsibility and control, and they can deliver it. And so we can use it as a tool. So that it's partly, the term is partly permission giving, that you can micro-eliminate here, and it breaks it down. If we talk about killing an infected country, people will go, that's a bit tough. But back to the pandemic analogies, we got through it, we did it, and we're out the other side of it. And so if people feel that I can't do everything, but I can do my patch, and I think it's encouraging people to, if we have lots of patches, we stitch them all together, we've done the job.
Great. And Tracey, any ideas on the horizon of where we would go?
I think for me, I would take it to those people who aren't in structured treatment. Thinking about drug treatment services, RNSPs. There's been a lot of talk both internally to Change Grow Live and externally with other providers around actually how do we formalise as such kind of the work that's being done to ensure that we are capturing and addressing risk appropriately. So I think given that I'm here to kind of represent drug treatment services, I would definitely go to our harm reduction and needle and syringe programs.
And what about, so I don't know a similar model up in Scotland, John, but we've got something that's very popular down here called GP shared care. So that's when a client of a drug service is prescribed OST. Usually they're deemed sort of safe, and I dread to use the word maintenance, but they've been on a script for a while. And then they get kind of farmed out to be managed in the local GP surgery. So their script is delivered through a GP surgery, and they're not so in touch, I would say, or there to drug service as someone who's new and needing a lot of the other help and support that can be given by drug service. So is there something there, Tracey, about going to ensure that we've eliminated clients within GP shared care settings? Are they included in the micro-elimination criteria in drug services?
So where we've got formal shared care contracts, then they are part of the caseload, so they would be included. I think we've got to really think about the kind of the wider primary care piece and how these people are kind of are supported and offered that test within kind of the GP setting as such. I know from an NHS England perspective, we've now got a national clinical lead focusing predominantly on primary care. So I'd like to see how we look to include this group of people, the shared care cohort, let's say, almost a two-pronged approach, so that we've got the opportunity to capture them via reviews with the drug treatment service, but then also kind of within their own GP practice.
Okay, great. And then I've got a final comment in the chat about antenatal screening. Do you have routine antenatal screening in Tayside, John?
We are moving to it. There was a lot of resistance initially from our obstetrician colleagues on the grounds that why were we picking on pregnant women when there wasn't anything we needed to do about it to do with their pregnancy. But clearly we are picking up about within Tayside 1 in 160 women delivering are Hep C positive.
That's a lot.
Yeah, and so it was, and the risk of transmission to the child, etc. So we're now moving towards that becoming a routine.
And is the risk to transmission still around 3 to 5%? Is there new evidence?
The evidence is still suggesting it's around 3
which
to
is
5.
1 in 20. Yeah. I mean, we were finding historically, and it's through no one's fault, but people were treated in the early days and sometimes not even asked, do you have kids and when were they born, kind of thing. So there is, and I know that England has been pushing for routine screening in antenatal settings quite hard. I think they've piloted it, they've proved it, and they are now just in the final arguments of the ethics of it. But that's a misunderstanding. Okay, so 1 minute left. Any final comments? There's a final question here is, do you think we're going to keep the elimination up? Our commissioner's going to keep being concerned with it? So anything on that, or just a final thought from you, John?
I think the cost of taking our finger off the pulse and not carrying on with the testing is relatively cheap. A couple of infections that then suck up huge amounts of, particularly when the contracts have gone for the drugs, will be expensive to them, but it will need us to advocate for that continued testing. So I think that's my take-home message.
Thank you. And Tracey?
Just to that point around commissioning, I think this is where, when we're looking at developing sustainable models and that business as usual approach, it's our job to try and influence our local authority commissioners to really think above and beyond what was maybe seen as the standard offer within drug treatment service contracts, and think more widely around hepatitis C and other bloodborne virus kind of pathways for both testing and treatment to kind of become the norm and part of core delivery moving forward.
Thank you. And thank you so much to all those attended and giving us your time, all the participants on the call. Thank you very much, John and Tracey and Georgia in her absence, for delivering your views on micro-elimination. They're fantastic. And I'm going to draw us to close just to say, please visit HCV Action website if you want information about them, and keep your eyes peeled for any more further webinars. Hope you've enjoyed yourselves. I will say goodbye.
Thank you.
Thank you.